Thank you so much for the organizers, and especially the PACE Hospital, Madhusudan, Ramesh. While he was introducing, one thing he forgot to say, I'm sure you all would know, that I am from Osmania Medical College, Hyderabad.
Oh, that's a great privilege.
So that is one of the most exciting thing, that I graduated from this beautiful city, which is getting beautiful and beautiful by the day. Every time you come, you see so much of changes. And thank you, Madhu, for that beautiful topic. Very, very close to me, pediatric acute liver failure, the etiology, diagnosis, and management. And I will not disappoint Ramesh and give comments on the Wilsons that he asked, and Viresh on the HIDA at the end of the talk, so I'll have to finish it. So while in adults we say acute liver failure as hepatic encephalopathy and liver disease, in children it's a little different. That's what I'm going to say, that in the liver failure study group, which was amalgamation of London, UK, USA, etc. So lab evidence of liver injury, INR more than 2 without encephalopathy. So in adults, we just say like encephalopathy is a major part. So this is the difference, more than 2 without encephalopathy or more than 1.5 with encephalopathy, 8 weeks from the onset of symptoms, because we know there is so many classifications I will not go into, but which keeps ranging from 4 weeks, 8 weeks, 6 months, etc. So our acute liver failure this is what we say, with no evidence of chronic liver disease. What causes it? As I've been asked, etiology. So viral hepatitis is very common in children, whether it is A and E. A is usually more. The other viruses we don't see so often, but in newborns, as highlighted by Ramesh in his comments about sick newborn, he said, and I wanted to add one more in that, can't see Ramesh, but was HLH, needs to be added in that sick list that we were mentioning besides this. And say merino and all also can give. And you all know, you were reading in the newspaper about this recent surge of merino in Delhi, that we were seeing the respiratory and the GI issues together. Hepatitis B is less often seen now. I did see in the first 10 years of my practice and not much. The next cause is what Ashish was talking about, a disease, a metabolic disease, which just presents to you with liver failure for the first time. So the common ones that we see is Wilson's, tyrosinemia, which usually is AC, acute and chronic, it presents. So Wilson's, and the other things is the mitochondrial fatty, and autoimmune liver disease in children can present to you first time as liver failure. Of course, we've all seen dengue cases presenting at liver failure, sepsis, MODS presenting. So this, wherever there is there, and DILI, D-I-L-I. DILI is drug-induced liver injury, like valproate. As I speak to you, I had a child, I was just messaging to shift to the ward. So that patient was an anti-epileptic on valproate, but developed hepatitis A. So the INR was 3.7, and fortunately, with conservative management, improved. So drugs and toxins like tuberculosis, paracetamol, valproate, despite all this, the cryptogenic variety universally, globally, is pretty high. More than a third, you're not able to. So these are all those, those viruses which you've not identified, or your genetic causes that you're thinking. So the next question is, how does this occur? Now, more than 50%, this is to just give you a rough way, that would be damaged or necrosed before your liver gets into failure. So when there is liver failure, there are endogenous toxins, and the various toxins like bile acids, bilirubin, prostacyclin, nitric oxide, which he was talking about, Viresh, indoles, metabolites, toxic, and the other ones like benzodiazepine, digoxin-like substances. All that we've been talking about, and we drew our attention away from ammonia and lactate in between for a couple of years. And we are back to what we learned as students at that time. Till now, ammonia is something which we respect most because easily to change. So ammonia and lactate is what we do. Because of this, there is the recent papers that you read will talk about the immune dysfunction that occurs because of these toxins. So the cytokine surge, we are talking about the TNF and interleukin 1-6 and all that factors, they have an effect on multi-organs, the various organs. The brain, kidney, cardiovascular, bone marrow activity, all this is going. And then the further liver damage via this vicious cycle, more necrosis, more apoptosis. How does encephalopathy occur? Because that is what disturbs us. So once this ammonia and the other endotoxins and the electrolyte imbalance, sepsis, I've been talking about the immune dysfunction and the cytotoxins, etc. So once they cross the blood-brain barrier and then ammonia is crossing, it absorbs water, glutamate is converted to glutamine, and then the brain swells, you are into cerebral edema, there is more oxidative stress, increased cerebral blood flow, increased intracranial pressure. So this is how we need to understand how we're doing. So when do you suspect it? If there's jaundice, fine. But please understand, in children, you may not have jaundice in hepatitis A, you've all read about it, and icteric hepatitis in children. So that becomes an issue when there is not much icterus and the patient is presenting to you with encephalopathy. So coagulopathy, a blood test is a must to detect INR. So one of my key messages when I speak to pediatricians is, whenever there is jaundice, you know clinically there is jaundice, definitely ask for an INR in a patient. How to manage this patient, as I've been asked by Madhu. So one is, I'm going to give you a couple of cases, but trust me that you can save 60+% patients of your liver failure without transplant if you are really aggressive. And some of you who are interested must come as an observer to see the way we treat. It's like 1:1 nursing, and practically we are blessed with a lot of doctors, and one has to literally adopt that child. And there are times when I don't sleep the whole night and messaging every 1.5 hour or 2 hours because you want everything to be, whoever calls are there, not always me. So the monitoring, the supportive management in ICU setting. Routine bloods, I don't need to say. CBCL, FT, RFT, PT, PDK, fibrinogen, DCT, FDP, G6PD levels in North India that we look into, peripheral smear. And then the etiology workup, viral serology. We always like to do Wilson's, ceruloplasmin, immunoglobulin G. So these are the ones which you commonly do because, as I said, Wilson's are not. Now, what is most important is you need to identify the patients who will benefit from transplant and who needs a transplant and maintain that condition till the transplant. So what becomes important is to transfer to a center where there is transplant facility. But as I said, the data at our place is 60% more we don't need transplant. So you have to be aggressive. So when you transfer, you must understand you're not always transferring for transplant, but to shift the patient once you are in encephalopathy advanced gets very difficult. And that is where you need to understand the beauty of communicating and doing this. Anytime you think that this patient is having early issues, some behavior, excessive sleeping or a coagulopathy, which is a increasing imbalance, or some renal AKI is setting in, or there is evidence of hemolysis. When there is hemolysis, as I teach my students, think of three things. One, hepatitis A with G6PD. Second, Wilson's disease. Third, autoimmune liver disease. So hemolysis is something which you need to act quickly, and I'll take in a case later on. And if there's been a family history of liver disease, you know. So the transport has to be not writing on a paper, please go to a tertiary liver center. That's wrong. In today's medico-legal era, a patient can sue the doctor for not helping him on a transport. Did you know that or no? So you have to communicate, you have to ensure that the transport facility is okay, whether it is air ambulance, whether it is road. Obviously you will, if a patient is grade 2 and you want to transfer, I repeat, 2, I did not say 3. You should intubate and ventilate and transfer. Because on the this thing, if 2 becomes 3, you've had it. So better to intubate when you are thinking that the transfer is there. The doctor, whether a PICU person, intensivist or an anesthetist, should be there with a technician. While you're spending money on the rest of the thing, don't hesitate to spend the money and pay that doctor heavily, who is going to accompany a senior and not a medical officer. Because the entire future, the cost of the transplant you're going to spend, and if you've not spent on your transport, it was useless. We do a lot of air ambulance and road ambulance. We have a complete transport team that Medanta is famous about. You keep seeing on the TVs with all these ministers and all that stuff. So that is what is our USP and strength. The transport team is extremely short, and we planted a pediatrician senior in the emergency most of the time for patients who come. So now my circle of care, I love to call this the circle of care, is I have to be looking like a hawk on the fluid and electrolytes every 4 hourly, if not 6. I have to look at the coagulation, which could be 6 to 8 hourly. I have to monitor for my intracranial pressure and cerebral. I have to look at the lungs. I have to be, the immune dysfunction that occurs will predispose to sepsis and shock. So this is one condition where you're allowed to give prophylactic antibiotics and antifungal, unlike any other thing. So what happens if I give more fluids? So it is like you can get into CCF, liver congestion, pulmonary edema, cerebral edema, kidney issues. What happens if I give less fluids? Again, there are issues with this. So that is the issue. So let's divide our goals. Goal number 1, of course, the supreme power, brain is my goal number 1. So my first goal is to prevent the cerebral edema. And we've all read about this, head and raised, quiet room, less stimulation. 30 people going in the room, 30 people don't have to examine. Usually one person had to examine, completely back-whack everything, heart, pulses, periphery, BP, each and everything, and then you set a protocol in a typed paper so that the whole paper is written and the rest can see. You target your sodium 145 to 55. If you know your kidney functions are good, mannitol is one of the best things to start with. If otherwise 3%, we give a bolus and then put into maintenance. The fluid balance is very important. Gone are the days when you would say, reduce the fluid by 30% and reduces. No. Monitor. How do I do it? Bedside ultrasound each ICU has. So in the ICU, you look into the IVC filling and look into the bedside. One message, if I have to say, that you're going to walk out of this room today is early CVVS, continuous veno-veno dialysis. If you want to take one message from my talk, please take this message, that early dialysis, early reduction of ammonia, early that is the way that I have change in the management of the patients over the years. So this helps to avoid fluid overload, dyselectrolemia, hypokalemia, hyponatremia, hypoventilation. So we are not sure. Yes, we've been talking about a bit of hypothermia, not great. Hypoventilation, nothing great. We keep our carbon dioxide around 30. We don't usually give anticonvulsants, but if there has been, before the transport, we are told that the patient was in grade 3, 4, so we give only then levetiracetam or phenytoin. So ammonia level, yes, rifamycin, lactulose. Hepamas has not been great on LOLA in the acute liver failure, but in ACLF and underlying, yes, and CRT I've already impressed to you on. So I set goal number 2 now is to prevent infection. So your prophylactic antibiotics, antifungal, care of the line, catheters, monitor for SIRS. So this is extremely important. Coagulation, we don't give unnecessarily FFP unless you're planning an invasive procedure. So the intensivists sometimes say when you're asking for a CRT and they have to put in a line, say, ma'am, can we please give FFP before a line? So I said, okay, go ahead. But so this is it. We believe in TEG. TEG helps you because your coagulation may be deranged. If your TEG is normal, you don't need to give anything. So now comes the hepatic support, which we've been talking about, which just like in dialysis, you remove your water-soluble toxins. How do I remove my protein this? And can somebody say something very important is missing in this deliberately because I kept it in the next slide? What is it that is mixing in the hepatic support device? Where I said removing of albumin and toxins. Adults have done more studies than us. And I'm going to quote a paper of 22, which we are going to follow. So plasmapheresis is what I didn't put into that because I kept separate start. We've been talking about Mars. It's pretty expensive. We did it initially. I think we don't. This is my favorite dialogue in this movie, Chashme Badur. The hero complains to his friend, my girlfriend is not good, she's cribbing. So the friend says, if you can't change the girl, change the girl. So he's not able to change the behavior of the girlfriend. So he says, if you can't change the girl, change the girl. What I mean is, when I'm not able to save the liver with my medical management, I have to change the liver, which is liver transplantation. Now, what are the challenges in liver transplantation? In ALF, ACLF, when to transplant, when not to transplant. So there are a lot of criteria, the King's criteria for paracetamol. We don't see so much, but just wanted to say that INR 6.5 is what you wait in the paracetamol. Non-paracetamol, just one, either the INR more than 6.5 or any three of the following, which we all know, bilirubin more than 3.5, etc. Then there have been new guidelines which it talks about INR more than 4. So by INR more than 4, you start your preparation for transplant in a child, and factor V less than 20% of normal. So there have been a lot of work with different papers talking about the predicting factors like lactate, high lactate, or low phosphate and factor V, and these alpha fetoprotein, etc. But I think there are a lot of challenges in an ideal score, and why I say is like the calibration, the discrimination, retrospective, missing data, age, incorporation bias, ICU admission, peak, all that. I think there's a lot of bias, and therefore it's getting more difficult for us to get. I did present this paper, but like a typical Indian. I did not write this paper, and that was wrong because now there are good guidelines, but I was one of the first one to have made this paper and presented it in the Asia meeting where we talked about prevalence of akin and pediatric ALF. Can akin scoring improve the King's College criteria, and should it be included as a prognostic model? So AKI, we all know the definitions and all, and what we concluded was when we included AKI, within 48 hours, if you're looking at a renal parameter, that should be included with King's College criteria. That helped in improving the positive predictive value and that. So now, when not to transplant, we've been talking about florid sepsis, multi-organ failure, HIV, Hep C is no more considered that because in the Western world, you can get grafts from these people. Extrahepatic malignancy, neurological damage. It's so easy. It's so easy for me to rattle. But imagine you're there and how do you decide this neurological damage? This was a child we airlifted from Kashmir, and young boy around 16, 15. And we, at that time, did a bolt. But to be sure what was, because we don't know what was the neurological status, usually pupils are pinpoint. Now we do resort to this optic nerve sheath. Just like in adults, we have the optic nerve sheath, which is the ultrasound of the eye, is less than 4.5 and a value of more than 5.1 needs attention because there's evidence of edema. So the challenges is bridge to transplant. What I mean is you decide a transplant and I get a donor while we are preparing. During that time, the patient should not conk off. Or I'm not sure I want to support the patient medically. So that's called bridge to transplant, and where to get the liver from and who can donate it in a living related setting. So now this was a 14-year-old boy who comes from Delhi, and hepatitis A, jaundice to encephalopathy 1 day and grade 3, and there was cola-colored urine. So I said, wherever there is hemolysis, I've already talked to you about, think about 3 conditions. So there is evidence of ICP, bradycardia, hypertension, pupil sluggish, optic nerve sheath diameter, 5.6 and 5.4. I said more than 5.1. Worry on this there. So we do go in like creatinine 1.7, ammonia 172, bilirubin 40, there is hemolysis, so direct is 26. So in this patient, both plasmapheresis and CRT is useful. I like to do plasmapheresis when there is hemolysis, your bilirubin and albumin, and if it is only an ammonia issue, we go more for CRT. But if it is the other parameters, especially hemolysis, then we like to go in for plasmapheresis. There's a paper for those interested. I thought I'll put it after last year only, 22, from the King's, whether it is time to incorporate it in the guidelines based on the adult data. So we do have some guidelines for CRT. What we say is an absolute value of more than 200 of ammonia or more than 150 couple of readings and not getting better. So that's how we are doing apheresis, we are doing CRT and all that stuff, control, and ultimately Wilson's and transplanted. So 7 years old, and this is very interesting, where she had jaundice for a month and abnormal behavior for 2 days. So it's like a long story, but 3 things I wanted to highlight in this is for the pediatricians, if there are any. The pediatrician did 1 INR, and after that, he did not do any INR. That was a mistake by the pediatrician. Let's learn. Because the parents, when they got admitted in a government hospital, the first thing they did was an INR, which was subsequently post-vitamin K was also fine. So this is the time they referred the patient and said the patient needs transplant. The patient was from railways. The railways referred to us, and now we were told that she did have a bit of posturing too, but immediately ventilated at that time. Child blood group O, mother O, father was B anyway fatty, and the mother's enzyme 110. So this is the time where I want to transplant and the donor is not ready. So this is your bridge to transplant. How I am managing this patient, that's a bedside CT, bedside spheresis, bedside CRT, all this we are doing, and this is the way you manage from 14th till 20th, till the mother's enzyme got better and we could take her for transplant. And then perioperatively we look into your oxygenation of jugular vein, etc. And the zenith of satisfaction was when she got up and she said, that's a video, my name is whatever, she's rattling her name, and more than anybody I distributed sweets because I thought if this was. So this purpose of this last case is just to tell you that you've heard about this dharam sankat. That is the thing which we all get in as transplant physicians and surgeons. This is something which I want you all to see. This patient had 28th February was admitted with fever and pain, abdomen, nausea, hepatitis A positive, INR 8.8, ammonia 320. Immediately that hospital said, please go to a transplant center. And when they came to a transplant center, obviously they connected and we sent in an ambulance. I said, please intubate there. Grade 2, but got them intubated. This child had ichthyosis, you can see on that. So the child was 33 kgs for 13 years with a length of 157. I say length because he was lying down and not standing when I measured. And his ammonia 320 outside, 280. So what I want to say was this. On day 1, within few hours, we started dialysis. Immediately we asked for transplant, INR 8. You don't need brains to say. But the family gave us the permission next day morning, 2nd. We stopped sedation this next day because the first night the child comes intubated, ventilated, and you stop the sedation. Mother consented, donor workup started, and sadly they needed a permission from somewhere to get the transplant. That transplant, so there were 3 lessons in this patient. So those people said us that we are going to give you permission by evening, that is day 2nd evening, and we kept waiting and the permission didn't come and the father also got delayed. And so the next day they gave us the permission by evening. So it is now day 3. I stopped my the sedation right 7 a.m. on day 2. But day 3 evening, still there is no response to any verbal communication, no movement, no trigger, and pupils were so small, pinpoint, that's difficult to talk about reacting. Optic nerve sheath was, it's written, it's 5.8 or so. Now, CT scan we did is suggestive of cerebral edema. Now, I have the permission for transplant. I have the donor ready, mother, and I know the patient qualifies all the criteria, but I am confused. Will the patient get up neurologically or not? So you have to be honest and confess to the parents that we're not sure this parent will, what is going to be the neurological status, and leave it for the parents to help you. This parent decided, no, we wouldn't sort of. And so the next day, INR unsupported was 4.5, so that was little better from 8.7, and ammonia we could manage the ammonia 160 the first day I did, yeah. So 280, 298, and then we went morning, that was within 8 hours, 10 hours, 166, and then we went in for an MRI because we thought MRI would be better to prognosticate the brain, except that you need to be off dialysis during that time. So metabolic encephalopathy, combination of hypoxic, ischemic and hepatic encephalopathy. That makes things even worse for you. Because if it is ammonia, it may be reversible. When they use the word of hypoxic, ischemic, then if you transplant, the surgeon and the hepatologist cannot be saved. Anyway, luck, as the patient was lucky in this case, that the INR improved and ammonia improved with my aggressive medical management, and the patient got better, and I was messaging from my seat there to discharge that patient today. But this is what, so easy to say neurological damage, but when you're there, it gets very difficult to say how. So that is the way this patient improved and finally got discharged. So my dear colleagues, I would like to sum up by saying that this is the data of the liver failures. We presented this somewhere, so I picked up that slide. We saw 20% cryptogenic. The global data was 40, ours was 20. Metabolic was 21. Sepsis infection, 9%. Drug-induced, 5%. Autoimmune, 4%. Hepatitis B, 4%. Viral hepatitis was 36%. So what I'm trying to impress to you is the metabolic. So it's not all viral hepatitis, which is 1/3, a decent 1/5 was metabolic too. That's what I wanted to highlight. This is the experience by January slide. In the last, we've done around 13 after that. So the slight preponderance of males still, 60% plus. The lightest baby that we transplanted was the lightest in the world, which was 2.1 kg neonatal hemochromatosis. We are probably popular for small babies, so we have 1/3 of our patients which are 36 and to a quarter of the patients who are less than 1 year. So my focus is liver failure today. So ALF and ACLF is 27%. So that is a good chunk of the transplant work that we would do. And in this metabolic causes in the, this is the ACLF group. Unlike the Western world, we don't see drugs so much like they see. And we've talked about the outcome, and we realized that in this paper, which was presented in ASLD around 5-6 years back, our ALF was 100%. You will say, how is it possible? Well, because in a living-related liver transplant center, ALFs do well, but the ACLF, when there is an underlying autoimmune, which we'd stop, I mean, we're doing more aggressive medical now, or Wilson's, or with hemolysis, or with that, that is the one you tend to. So if you see, the ALF per se was 100, but the ACLF was 84 if I take, as compared to 92 of the chronic liver disease. We published 200 earlier, and now we will be soon publishing our 450 wala case. So my dear colleagues, the first liver failure in India was done 2004, 9 September. I salute this mother who trusted me when I said, we can save your child, who was 8 years then. She trusted that, yes, she will go ahead to support her child. So this was the first liver failure in the country that we had transplanted, and we've come a long way, nearly 20 years it's going to be. So we do have a very good outcome for acute liver failure. You can see that they're 93% or that. I am very grateful to Almighty and Osmania for educating me and the beautiful team I have. We started our story from the first successful cadaver liver transplant in 2003. I did not go home for 1 week. I was planted in the room. First 50 liver transplants that I did in Gangaram before I moved in 2010 to Medanta. Nadeem is here. He's seen me with my sincerity. It is, I sit in the room for the patient for the first 20, 30. I didn't go home for weeks, and then subsequently would sleep there till all 50 were successful. So we did the first combined liver kidney, first swap liver transplant, and I remember going to Nirman Bhavan to get that permission because there was no permission for doing swap transplants liver, which I could manage by spending a lot of time with seniors there. The first domino liver transplant where in an MSUD you can give the liver to another person. The first robotic donor, my surgeons, I should say 2011 in the first in India. The first ABU was the first ABU was a child. That child who trusted, the father trusted, he said, go ahead, and we went ahead. And so that was in 2012, and then the hepatopulmonary syndrome, the lightest baby, and you will be surprised, in a 14-year-old boy, 92 kg, we had to do a dual lobe. Two sisters, one gave the right lobe and the left lobe. So we had to do a dual lobe. And I would acknowledge my mentors, Dr. Arya, Dr. Mohan, Dr. Sama, Dr. N. Kirora, my family, my parents, my teachers who have been there, my training which was from Birmingham, and of course the media, if it wasn't for the media, and I could live the dream of my father when I got that award for liver transplant setting up in India, the Viceroy Award. So I bow to all of you and the Almighty. The take-home messages are, goal is to support the liver, prevent brain edema, infection, bleeding, fluid imbalance, and other organ damage. You have to be like a hawk with the patient monitoring every 4 to 6 hours. Early recognition and prompt management of encephalopathy and cerebral edema. Early intubation, early CRT, and plasmapheresis are emerging now as the key for improving survival. Early transfer, safe transfer, using a transport team, understanding the guidelines of transfer, very important. Communicate with the parents. The parents should be communicated by the team earlier also that they will need a liver transplant so that they will trust the center where they're going. Right timing is essential. Don't be over-enthusiastic to do it too early or too late. And that is the beauty of identifying. And the outcome is very good in a living donor setting. I thank my entire team for their support. Thank you.
Thank you very much, Madam, for this extensive talk on covering right from the etiology, diagnosis, into the management, and when to think about preventive care. And I think as intensivists, what we do is anticipate early and active. That's what you've kind of highlighted. Anticipate these children because they can get sick very quickly. And if you do intensive care management very well, I think many of them can be prevented going on to further deterioration. Thank you very much.
Yeah, so I think he said a very important point. There are a couple of, like Julia Wenden is very popular, she's an hepatologist who's into. So in the pediatric side, I'm a little bit like that, where being an hepatologist, I'm very fond of critical care. And actually, I think I owe a lot to liver failures, because as you saw in 9 years, we've had more than 250. So because of that, I did head critical care for some time because of the passion of involving into critical care. And it is very important, but wherever you have a person who's dedicated and understands that how different it is to manage liver failures than a routine case who's into mods, you put on the ventilator and you're off. So it's not like that. Because the patient I was talking about, that ammonia, I was a little upset with my resident because ammonia after 4 hours, was still, from 290 or 280 or 290, he should have called me up so that I could have changed the setting of the dialysis. He thought he will call me at 8 a.m. So this is what you need to tell your team, that you should connect and we will change the settings.
Thank you.
Okay, Dr. Neelam, that was a great talk. Congratulations to you and your team for the great work you are doing. And from Hyderabad ki beti, we are really proud of you. And I would like to know what is the role of anacetyl-cysteine in case of
Excellent.
acute liver failure?
I realized that I didn't talk. There have been papers about N-acetylcysteine and paracetamol, no doubt. But having said that, I was talking about that glutathione and all that when I did the hepatic encephalopathy, beautiful animation, how the brain is getting thicker in that. So N-acetylcysteine does provide you a little substrate. I use it in all cases. And there have been papers where they say that it may not change the outcome, but some morbidity or whatever. So we still use it. And
how long
I would not
do you use
want
it,
to
madam?
not use. Sorry?
How long do you use it?
Yes, usually either two things, for 5 days at least, or because that is the time either my patient is improving or gets into a liver transplant. So one of the two, or the INR goes down to 2. So the patient I was talking about, the Valproate with Epi, came with 3.9. Today's INR is 1.8 or so. So I would stop.
Madam, very crispy talk with very good take-home message, madam. But one doubt, madam. You said the cryptogenic cause of liver failure is 40%, so it's a very huge number. Is it because the patient is not giving enough time to work up before he succumbs, or anything else we can do?
Yeah, so one thing, what I wanted to say was that in our center, we don't allow the patient to die. Because it is like whatever the patients, and therefore when I did that Akinka data, I had to exclude all patients who underwent liver transplant because that data will be skewed. I have to take patients, so it is easier for government setup because your patient who dies or survives are very clearly written. So in us, anybody who goes LAMA, leave against medical advice, what you say is basically you have to take as death. Because, so majority of them agree for transplant. So what I wanted to say was that if you do aggressively management of a liver failure, 60% plus you will save medically. So now you're left with 40. In that 40, in my center, at least 38, 35 consent for transplant. A very small 5% who do not consent. And fortunately, we look into CGHS and ECHS. I like that about my system, where it's you get 150 rupees pay, whatever, it's like practically free. 14 lakhs transplant, even governments are not doing. But we do it for 14 lakhs, both CGHS and ECHS. So there are patients who get a support, and then we have fortunately for children, we have a transport fund. Earlier, I used to get 1 crore an annum fund, 1 crore an annum. Now, those funds have decreased post-COVID, I'm not getting. But we do get some support for patients who need money.
Thank you so much, madam. For the want of time, we will have to restrict our discussion
I
over
wanted
here.
to just make one comment to all the surgeons with folded hand from a girl who hails from your city, that it is time that the pediatric surgeons should call and do a party with the pediatric gastroenterologist, hepatologist, whether women or men. Because we all are working like this, which is wrong. I think we need to work and embrace each other. It is high time we need to be humble and respect each other's thoughts and all. So the message is, I don't want you to walk out of this room thinking that I said HIDA is useless and Viresh said HIDA is wonderful. And the chairperson, I forgot his name, who went to Japan and who is from Nilofer, if I'm not mistaken, who said liver biopsy is useless. So I am not offended that liver biopsy is useless, but let me say that if a patient comes to you less than 6 weeks of age, you have time to give 5 days and do HIDA. If the patient comes beyond that, go for liver biopsy. Liver biopsy, we have produced like 20 years we are training and the residents, and we have pediatric gastroenterologists all over the country. Liver biopsy in my center is morning and evening. I give by evening, latest to next day morning at 10 a.m. But you'll be surprised, it's not me and my. There are a lot of centers who give liver biopsy in 1 day, maximum 2 days. So thinking that, so liver biopsy utility is excellent, 98% in good centers, 95% average for biliary atresia. Beauty is it tells you fibrosis and cirrhosis. You can decide and discuss with the parents. Money is not an issue. If the liver biopsy is extensively fibrosed, you talk to the parents, they may like to go for a primary liver transplant. So India has grown a lot, and it is not true to say that. So we need to love and embrace each other and discuss and homely and all these points. That's all I had to say.